Introduction. Hirschsprung disease is a developmental disorder of the intrinsic component of the enteric nervous system. It is a congenital anomaly and a familial condition caused by migratory failure of neural crest cells leading to abnormal innervations of the bowel, that is, absence of intramural ganglion cells, more commonly in anorectum, but can involve the entire intestine. This is also known as megacolon or congenital aganglionic megacolon. History of Hirschsprung's disease. 1691 Rush Latin texts, 5-year-old child dying from an intestinal obstruction. 1800, Battini, an account of a child with congenital megacolon. 1886 Harold Hirschsprung, newborn's bowel movement as a result of dilatation and hypertrophy of the colon, autopsy findings. 1901, Tittel, histologic findings, the absence of ganglion cells in the distal colon. 1946, Hirschprung, the first surgical recognition of aganglionosis as the cause of congenital megacolon. 1949, Swenson, Pathophysiology and Definitive Operative Treatment, rectosigmoidectomy with preservation of the sphincters. Incidence. The incidence is 1 in 5,000 live births. It is 4 times more common in males than in females and follows a familial pattern in a small number of cases. Associated anomalies include urological anomalies, 2.2%, anorectal malformations and colonic atresia, 4.5%, small bowel atresia, 1%, deafness, 2.2%, and cardiovascular anomalies, 5.6%. Pathophysiology of Hirschsprung disease. Hirschsprung disease results from the absence of enteric neurons within the myenteric and submucosal plexus of the rectum and/or colon. Enteric neurons are derived from the neural crest and migrate caudally with the vagal nerve fibers along the intestine. These ganglion cells arrive in the proximal colon by 8 weeks gestation and in the rectum by 12 weeks gestation. Arrest in migration leads to an aganglionic segment. This results in clinical Hirschsprung disease. Types of Hirschsprung disease. 1. Short segment or classical rectosigmoid. Involving rectal and rectosigmoid. Comprises 70% cases. 2. Long segment Hirschsprung's disease. Involving more than the classical segment, reaches up to descending colon. 3. Subtotal Hirschsprung's disease. Involves up to mid-transverse colon. 4. Total colonic aganglionosis. Involves entire large colon. 5. Total intestinal aganglionosis. Extending to ileum and even jejunum. 6. Ultra-short segment Hirschsprung's disease. Limited to distal 2 to 3 cm of rectum. Clinical manifestations of Hirschsprung disease. Newborn period. Failure to pass meconium within 24 to 48 hours after birth. Refusal to feed. Bilious vomiting. Abdominal distension. Infancy. Growth failure. Constipation. Abdominal distension. Episodes of diarrhea and vomiting. Signs of enterocolitis. Explosive, watery diarrhea. Fever. Appears significantly ill. Childhood. Constipation. Ribbon-like, foul-smelling stools. Abdominal distension. Visible peristalsis. Easily palpable fecal mass. Undernourished, anemic appearance. Laboratory studies. Complete blood cell count, to ensure that the preoperative hematocrit and platelet count. Coagulation studies, to ensure that clotting disorders are corrected before surgery. Imaging studies. Plain abdominal radiographs may show distended bowel loops with a paucity of air in the rectum. With regard to barium enema, Avoid washing out the distal colon with enemas before obtaining the contrast enema because this may distort to low transition zone. The catheter is placed just inside the anus without inflation of the balloon to avoid distortion of a low transition zone and perforation. Radiographs are taken immediately after hand injection of the contrast and again 24 hours later. The classic finding of Hirschsprung disease is a narrowed distal colon with proximal dilation. Retention of rectal contrast for longer than 24 hours after the barium enema also suggests a diagnosis of Hirschsprung disease. Other tests. Anorectal manometry detects the relaxation reflex of the internal sphincter after distension of the rectal lumen. Echocardiography and chromosomal analyses may be warranted to evaluate for any associated congenital conditions. Procedures. Full-thickness rectal biopsy. The definitive diagnosis of Hirschsprung disease is confirmed by a full-thickness rectal biopsy demonstrating the absence of ganglion cells. Suction rectal biopsy. Simple suction rectal biopsy has been used to obtain tissue for histologic examination. Medical care. The objectives of medical care are to maintain normal fluid and electrolyte balance, to minimize bowel distension and prevent perforation, and to manage complications. Initial therapy. If a child with Hirschsprung disease has symptoms and signs of a high-grade intestinal obstruction, initial therapy should include intravenous hydration, withholding of enteral intake, and intestinal and gastric decompression. Decompression. Decompression can be accomplished through placement of a nasogastric tube and either digital rectal examination or normal saline rectal irrigations 3 to 4 times daily. Diet. A special diet is not required, however, preoperatively and in the early postoperative period, infants on a non-constipated regimen, such as breast milk, are more easily managed. Antibiotics. Administer broad-spectrum antibiotics to patients with enterocolitis. Hirschsprung disease surgical management. Surgical management of Hirschsprung disease begins with the initial diagnosis, which often requires a full-thickness rectal biopsy. Traditionally, a diverting colostomy was created at the time of diagnosis, and definitive repair was delayed until the child grew to a weight of 10 kilograms. A number of definitive procedures have demonstrated excellent results when performed by experienced surgeons. The most commonly performed repairs are the Swenson, Duhamel, and Sove procedures. Swenson procedure. The Swenson procedure was the original pull-through procedure used to treat Hirschsprung disease. The aganglionic segment is resected down to the sigmoid colon and rectum, and an oblique anastomosis is performed between the normal colon and the low rectum. Duhamel procedure. The Duhamel procedure was first described in 1956 as a modification to the Swenson procedure. A retrorectal approach is used, and a significant segment of aganglionic rectum is retained. The aganglionic bowel is resected down to the rectum, and the rectum is oversewn. The proximal bowel is then brought through the retrorectal space, between rectum and sacrum, and an end-to-side anastomosis is performed with the remaining rectum. Sove, indirectal, procedure. The Sove procedure was introduced in the 1960s. The mucosa and submucosa of the rectum are resected, and the ganglionic bowel is pulled through the aganglionic muscular cuff of the rectum. The original operation did not include a formal anastomosis, relying on scar tissue formation between the pull-through segment and the surrounding aganglionic bowel. The procedure has since been modified by Bowley to include a primary anastomosis at the anus. Anorectal myomectomy. For patients with extremely short segment Hirschsprung disease, anorectal myomectomy is an alternative surgical option. The surgeon removes a 1 cm wide strip of extramucosal rectal wall, beginning immediately proximal to the dentate line and extending to the normal ganglionic rectum. The mucosa and submucosa are preserved and closed. Procedures for long segment Hirschsprung disease. Patients with total colonic involvement require modified procedures to exclude the aganglionic colon while preserving maximal absorptive epithelium. The goal of these procedures is to bypass the dysfunctional bowel while maximizing the chance of postoperative nutritional function and growth. Nursing care of the child. Preoperative. 1. Assist in emptying the bowel by giving repeated enemas and colonic irrigations. 2. If abdominal distension is not relieved by enemas, discomfort is significant, and rectal tube insertion fails to give relief, consult doctor for a nasogastric (NG) tube. 3. Offer pacifier for infant to suck if on parenteral fluids. 4. Encourage parents to hold and rock the infant. 5. Maintain position of comfort with head elevated. Offer soothing stimulation, example, music, touch, play therapy. 6. Offer small frequent feedings. Low residue diet will aid in keeping the stool soft. 7. Administer parenteral nutrition if feeding causes additional discomfort because of distension and nausea. 8. For older child, provide demonstration and written and verbal instruction to family for saline enema administration and use of stool softeners. Postoperative. 1. Change wound dressing using sterile technique. 2. Prevent wound contamination from diaper. 3. Prevent perineal excoriation by thorough cleaning and use of ointments after the infant soils. Postoperative stool scan number 7 to 10 per day. 4. Use careful hand washing technique. 5. Report any wound redness, swelling or drainage, evisceration, or dehiscence immediately. 6. Suction oral secretions frequently to prevent infection of the tracheobronchial tree and lungs. 7. In older child, encourage frequent coughing and deep breathing to maintain respiratory status. 8. Allow the infant to cry for a short period to prevent atelectasis. 9. Change position of infant frequently to increase circulation and allow for aeration of all lung areas. 10. Maintain patency of NG tube immediately postoperatively. 11. Maintain NPO status until bowel sounds return and the bowel is ready for feedings as determined by the physician. 12. Provide frequent oral hygiene while on NPO status. 13. Administer fluids to maintain hydration and replace lost electrolytes. Begin oral feedings as ordered. 14. Support the parents when teaching them to care for their child's colostomy. Reassure parents that colostomy will not cause delay in the child's normal development. 15. Involve the entire family in teaching colostomy care to enhance acceptance of body change of the child.